into the chat. And last but not least today, we have Russel Mckee, and Yuli's going to talk to us too about his company in just a couple of minutes. But we've got Russel Mckee, who's the Chief Commercial Officer for VendRx. Russell's career has been spent serving at the intersection of technology and healthcare innovation. He's a founder and a board member for VendRx, and leading the transformation from point of care to catalyzing industry transformation. Previously leading NIC and BIC in pharma, healthcare data, capital equipment, and med device, he's founded businesses for medical product distribution and retail data systems. He has a BS in biology from the University of Utah and dual MBAs from UCLA Anderson and the National University of Singapore. So Russell, take it away, guy.
Thank you, Susie. I really appreciate the invitation from InnovatorMD, Ruchi, Dr. Uli, fantastic, and judges. Glad you stayed, and everybody that remains online. I'm the last presenter. I'm really glad you stayed. Let me go ahead and share my screen. I'll tell you what, I've learned a lot already so far today. I picked up a nice little tip from Dr. Wang, and I already changed the one-liner for my intro slide. We're going to get to it in a second. VendRx, we do on-demand prescription fulfillment. We leverage patient-facing automation to make it easy, fast, secure, and providers to deliver prescription to their patients on the spot. So on the right, you see some of the eye-popping hardware. That is just really a very small part of what we do, and we'll dig into it. So I like this quote, and this is not an audience where I have to explain or spend much time explaining the impact of patients not getting their meds. It's been reported that up to 1 in 3 new prescriptions never get filled. And a lot of the conversations we are having with hospital systems now for their ER is because they're seeing patients back the next night and then the next night. And it's because patients are not getting their meds, because most people in this use case, most patients go through after the pharmacies close, if the hospital still has outpatient pharmacy, and many don't. So, well, we know how it impacts patients, but we really haven't solved the problem. We're still scratching our heads a little bit as an industry. But it really, at the root of it, we've got great providers, both on the physician side and pharmacy side. They all want to help patients get their meds, but the legacy model is inefficient and it's too costly. This quote right here popped up on the 13th. We've seen a lot of this, or haven't we, over the last 2 or 3 years? Pharmacies are closing. They can't make their operations work. So it was hard for patients to get their meds. Now it's harder. So, and patients, I'm one of those patients. When it's hard, I just don't get around to it sometimes. And so how do you solve this? Well, in the words of one of our early adopter physicians, don't send your patients out into the wild to go get their med. Provide it for them on the spot. Well, how do you do that? Good luck hiring more staff in today's environment. I hear those stories. If you can train somebody to do a manual process around dispensing and they're committed to it, good luck keeping them. And if they don't want to do it, why not employ automation that will do it for them a lot more efficiently, a lot more simply, and without error? That's what we do. We do it in 2 places. Many people, even in the physician world, don't know that physicians can dispense to their own patients in 45 states with regulatory nuances, but in 45 states, physicians and providers can dispense to their own patients, but only a smattering do. Because if they've tried, and all of our customers are such healthcare providers, if they've tried, they know what a pain in the butt it is to dispense through manual means. It doesn't work. It's pushing a square boulder up the hill. It simply does not work. So we enable physicians to dispense to their own patients in their own clinics. Either one of the tools that you see in front of you can do that. They have different levels of automation and different cost points. We fit them for the right environment. Pharmacy, that's the model, that's the world that we know. Pharmacists do a heck of a good job. All the ones I know, I've got personal friends and family that are pharmacists. They're frustrated too. They spend a lot of time doing mundane tasks that they don't want to do. They want to practice at the top of their license. They're not, because of inefficiency. So we can help them too. So these hardware, and this is an important point, these hardware pieces that you see can be configured either to serve in a physician environment or a pharmacy environment. Now, If it's going to work, I heard a couple previous speakers hit this point. I won't belabor it, but if you add new workflows into a busy clinic environment, it's goodbye. Your product is a boat anchor. So we've eliminated all that. Has to be stable, has to be secure. We've never had a bad dispense. Our technology, if it sees a bad barcode or something like that, it just quarantines the product. We've never made a mistake. It's not that there hasn't been quarantined products, there have. But it has to be simple and it has to be flexible. In this 10 minutes, I won't have time to go into all the IP. I've got a picture of the inside of our machine on the top picture there. What you see is a two-dimensional grid there. We store medicines by cell, not linear columns, not the old school vending machine. Our only one competitor in the pharmacy market does it that way. What this allows in medicine is for you to have a much broader formulary, which you need. If you're taking generic Lipitor or atorvastatin, you may have 10 different iterations in your practice, 10 milligrams, 20 milligrams, 40 milligrams, 30 count, 60 count, 90 count. If you're going to serve your patients, you need to have all of them. We're the only ones that can do that because of our design, which we have a patent around. We have 4 patents on that big machine and patents pending on our new machine that's bound below, that's really positioned for physician clinics right now. Urgent care, I'll get into that. We've got patents pending on that, and the patents tie to how we manage data. So we are the only company out there that's providing automation from a hardware perspective in the physician environment. We've got a competitor kind of too on the pharmacy environment. We believe our mousetrap's much better. I can speak to that if people have questions outside of this conversation. All right, let's go into just a little bit how it works, because this is where the questions come from. In the onboarding process, we hook everybody up with suppliers. We know them all. We're agnostic. We don't have marriages with them at all. We just find best price and best reliability for supply. That becomes EDI. So the ins, think of it as ins and outs. The ins are always automated and it's unit dose. So it matches the prescribing behaviors of the physicians or practitioners in that setting. We can even do it in a hospital because we have data from our customers. Or we can do it in a hospital up to about 85% because they're your generic medicines. They're the stuff that people go through. Our product is not for specialty meds. If you have questions on that, we're not going for that market. We want stuff that can come in a bottle or a box, a tablet or a pill, and we can serve almost all of them. All right, I put this team slide early on because it tells the sequence of this company. And I do want to hit a point right away. The company's been around for a little while, certainly longer than me. It was the original founder was Samantha Jeffrey. She runs clinics, still does to this day. She knows the pain points of patients and providers. It guides what we've done with this product, really important. Trent came along, her brother is a CEO and he's a technical wizard. And if there's any frustration I have, it's taken us a little bit longer than maybe we would have liked to. But as Steve Jobs says, sometimes you go get the wave, sometimes you have to wait for the wave to come to you. It has. He spent a lot of time perfecting this product, and we've seen how important that is in clinical environments. You can't have failures, or they'll push the technology out. We've got a guy who spent 30+ years building robotics, nuclear particle accelerators, etc. This guy is an intersection of hardware and software. He's a real genius, and he's got a team of people working for him. And then I came along most recently and trying to put a little bit of a commercial muscle about putting all these products to the right markets, which is what I'm going to show you next. So we are selling. We have almost no attrition. Our focus, I'll show you in a second where our focus is, but the medicines come from supplier and it's bought by our customers directly, not us. We're not in the middle of that. And our customers they then sell in a pharmacy environment. They can do insurance and physician environments. They typically choose not to. They can sell on a cash basis. It's all generics for the most part. And their margins are such that they can pay for their price to us and their cost on medicine at these numbers. 2 to 4 dispenses in a day in a physician setting, or for the VendRx small product, wall-mountable product. For the big system, 6 to 11. These are real numbers pulled from margins that we see with our customers, meaning that if you're a physician who dispenses more than 3 or 4 dispenses a day and you can capture them, you're now in a position to better serve your patients and make some money. And they do. A year ago, we couldn't have talked about almost any of these customers. We're serving them now partly because VendRx on the left has just hit the bullseye better than we could have imagined. We only launched it in October. We are now filling orders till the end of the year. And part of our ask at the end of this conversation is so we can get those products out faster. Carbon Health's under contract. We've delivered a bunch of clinics in the Bay Area. We've also delivered Montage Health in the Bay Area. I'd be happy to set up a visit with you on the call because I know you're located there if you want to see it. Excited to report next week we're going out to Well Street, one of the biggest urgent care chains on the East Coast, and we're starting with them. And their biggest question is how fast can you scale? So we'll have to figure that out with your help. We've got lots of other customers on the hospital side. That's how I break it down I kind of break it down by product. It's the VendRx, mostly positioned for physician markets, or the big system positioned for pharmacy and hospitals. You can see who we're working with. The one I'm real excited about, and some of these are under contract on the right, some of them are budgeted, but not yet under contract. So Multicare is under contract. We'll deliver to them. Montage is. OnMed, we've sold 10 systems to. We're building more. Stanford, we're on a budget line item, but not under contract. NOMI, we're very close. They want to put it in the Miami International Airport. This is what I want to light you guys up about. The future of pharmacy. It's not just serving, it's serving wherever the patient is. And that's in public places. It's not last mile. That's for chronic meds. There's still a purpose for that. But for acute meds, you have to avoid the expense of last mile. And guess what? Patients are not always home or where they see the product. So
1 minute.
where are we? What's that?
1 minute.
Oh boy. Okay. Urgent care on this urgent care. I just want to see what the market size is for urgent care by itself. 40 million. There's no player there but us, and we're taking it over. We haven't had any push out. You saw some of the other customers we're going with. We can get that quickly. Boy, it's huge. Any physician that can dispense 3.5 dispense or more is viable. That's a $5 billion market of the 500 billion plus that is the retail prescription medicines. There are other markets outside of that we have our eyes on. All of these sub-markets, just take a quick glance. These sub-markets our customers have come to us and say, we want your product to do these things. We're working on it. It's real exciting, especially naloxone, that's just hot right now for the opioid pandemic. Okay, final slide. I'll stick this in 20 seconds or so. We're thinking we want everybody to participate in what we're doing. We want them to be excited, because if you've ever had a bad pharmacy experience, had to wait till tomorrow, had to wait till Monday to get your medicine that we all have, you should be interested in doing this. So we want to open up our cap table for a lot more investors. We're thinking about crowdfunding. We'll raise up to 2.5 million. We don't actually need that to break even. We'll do that at the end of the year just on operations. But what that will allow us to do is to completely cement ourselves as the innovation leader for this space with no near competitor, especially on the physician side. We will more quickly serve the orders that we have out. We'll get to 5 million revenue by Q1 of 2025. And we've already been engaged. We've already been approached by a couple for interest in buying us. We think we would need to get a little bit bigger to drive the valuation we want. So that's where we are. I would love to test the waters on crowdfunding. If you have $500 in your pocket and this is an idea that you'd be interested in, reach out to me. This is just a survey. I just want to test the waters, and we'll make some decisions after that. And with that, I would like to thank you for hearing me out here at the end of this group.
Thanks so much, Russ. Great presentation. And we've got just a couple more minutes for questions if any of our judges would like to ask any.
Yeah, thank you for the presentation here. Machines, it's not set it and forget it, right? Can you speak a little bit to the maintenance? I'm familiar with like Pyxis and Parata machines and such, and certainly they don't just run by themselves. Can you speak a little bit to that?
Yeah, absolutely. So I think of it's the enchilada, right? All of the parts that make up this enchilada are for other industrial uses with much, much higher and more demanding cycle counts. So we did put our first system. All the systems we're building are now, they're new generation, but we have built a number of systems. All of them are in service. The first of which was put into service in late 2017, still operating well. When we see things, it's like a print board going down, it's rare. What we almost always see is internet going down. So we expect about a 99.7% uptime. We offer a 2-year warranty. After that, there is a service and maintenance plan that they can purchase at a reasonable price. Does that answer your question?
Okay, and in terms of the inventory and such, that's all handled by the organization, not by your team going out in the...
Yeah, absolutely. So on the onboarding process, we hook them up with suppliers. We know who they are. We know who the best ones are. They can be wholesalers now. They do a unit dosing as well, or repackagers for certain meds. And we hook that up, EDI. And so what you didn't see, because it's hard to present in 10 minutes, is all the back-end enterprise software that drives all of this. This is the smallest part of it. So your inventory, ordering, and replenishment, that's all going behind in an automated way. let's just say you set par levels, it's constantly aggregating to a cart, constantly releasing orders, constantly be sent to the person who can receive it, and then go put it into the machine, which is a simple process. Put it in, it looks like a wine rack. Open the panel because you have a right to do so. Put the medicines, boxer bottles, in what looks like a wine rack of 52 slots. Push the door, push load, off you go, back to work. That's kind of how that's how it works on the replenishment.
Okay, so like if they need to clean in such, if they're replacing that cell with other types of medication, not to cross-contaminate, that's all.
They don't
done by
have to do any of that. So it was hard to see earlier, but there's the inventory zone is removed from the loading zone. So if you open the back panel on the screen that you see right here, you open a front steel panel, what you see looks like a wine rack. You can't reach through that wine rack and see inventory. In the inventory zone, all over on the inside of the steel box is what looks like a two-dimensional array. The robot grabs the bottles or boxes and goes and places those randomly in all those cells. There's no cleaning required. Certainly no human has to be involved in that process. The bottle uses industry convention. The industry stayed with barcode, didn't go to RFID, and it probably will. But it reads a barcode that comes from the supplier. We know what all that is. That tells us the NDC, it tells us a lot number, it tells us the expiration. And that gives those levels of data are really important. We immediately can quarantine if there's a recall, and we've done that. You always dispense medicine that's first to expire. The robot keeps track of all that, so you don't have to, and your staff doesn't have to. All you have to do is unload with a card swipe and your PIN number for security purposes, open the panel and start randomly placing medicines into the slots. Close the bin, push load, say goodbye.
Great, fantastic. Any other questions? Martina?
Yeah, so can you please confirm that this machine is being operated by healthcare professionals, not the patients themselves?
Yeah, this machine here is self-serve by the patient. I'm going to go back a couple slides. It's a great question.
Because it has implications on things like possibly minimizing medical error or how things are billed and other stuff.
Yeah, so those are good questions. There's a couple that I feel they're embedded into that. So the machine to the left, that is patient facing. So on the front end of this, we hook them up on the SureScripts network. That's what all physician offices and pharmacies use with our EMR to send prescriptions to pharmacy A, B, or C. Now they just send it to themselves because now they're pharmacy D. Even in physician office, it's set up exactly that way on the same network. So there's no workload, there's no workflow changes for the provider. They write the prescription through their EMR as they always do. The provider or the staff says, hey, do you want to have it? Would you like to have it here? Our providers say 9 out of 10 times, patients say yes, they want that convenience. That shouldn't shock anybody. I know I would. So then it waits in the cloud. When a patient presents, it asks them to validate themselves with the birth date. And then if there's payment required, they can pay right at the machine, and it drops the medicine in the tray in about a minute. This is the one sacrifice for the mostly automated system on the right. That is staff facing, and that is the trade-off for a much lower cost point. It automates everything else. So what happens, we call that VendRx in the physician office. What happens in the middle screen there, you see what we call a prescription checkout. A patient goes and checks out just like they do on the big machine. When that happens, as soon as they get their receipt, simultaneously a label prints at the VendRx. There's a light that goes on. It tells the staff the label's waiting for them. They scan that label. A bin opens. They grab the medicine out. They put the label on the medicine. They close the bin. It asks them to scan again as a redundancy for security. And it says, yep, that's the one. You got the right one. And you put the label on, hand it to the patient. Happy patient. Go start feeling better.
This is fabulous, Russ. I'd love to see this in it working in real life somewhere. So it's very cool, and it would be very convenient as a patient.